It's my pleasure to introduce our next speaker, although I'm not sure he really needs this introduction. So for those of you who don't know Dr. Joel Gelfand, he's a professor of dermatology and epidemiology at the University of Pennsylvania. He is a national and international expert in the area of psoriasis, very well published, but probably most well known for his work in the area of cardiovascular disease and psoriasis. He is also conducting a large 1,000 patient study currently looking at the use of office-based and home-based phototherapy. So really, he's made some great contributions in the area of psoriasis. And today he'll be talking to us about recent advances in the therapeutic management of psoriasis.
Thank you for that nice. And I will walk around, talk around to you folks today. What she didn't mention is that I'm now a native of Philadelphia. I grew up in New York. Spent 10 years in Boston at Tufts and then Harvard Medical School, so it's good to be home again. But now I live in a home with the Philadelphia Eagles. So, you know. Couple of cheers, people? Come on, couple of cheers. I mean, come on. The Patriots win it every single year. Give us a little help here. All right, so disclosure slides here, my titles. Everything I'm going to show you today are slides that we create. There's no industry involvement in this work. And essentially, these are complicated objectives here. Mainly, I'm going to try and bring you up to date about where we are with biologics and psoriatic disease. And since this is a general audience, I'm going to mix in a couple of pearls for the rheumatology community as well as the GI community, of course, for those who practice general internal medicine. With that in mind, how many people in the audience are rheumatologists? Give me a raise of hands. Okay. And how many people are gastroenterologists? Give me GI folks. Good representation of GIs in Boston. How many people are derms? How many people are non-affiliated? Okay. Any general internists in the room? Couple. Okay, excellent. We have actually a great mixture of folks. It should be fun. All right, so I want to start talking about what is moderate to severe psoriasis, since we're a mixed audience. And so we have a public health definition and we have a clinical definition. And so the public health definition, when I'm doing epidemiological studies, is basically patients who have 3% or more of their body surface area involved. The clinical definition in trials is typically like a BSA of 10% or more. But in clinical practice, that's not what we use. We actually tend to use patients who we think are candidates for systemic or phototherapy, the oral biologic treatment. And typically this is patients who have disease involving more than 5% of their body, because it gets very difficult to manage that topically over time, as well as folks who have sensitive and difficult to treat areas. So someone can have very limited psoriasis in their palms or their soles, or in the genital area, the scalp, and those people we might consider moderate severe and candidates for getting systemic agents. And so based on these definitions, we estimate there's about 1.5 million people in the US with moderate severe psoriasis, about 30 million people worldwide. And this is important from a public health point of view to our patients, because from a variety of work that's gone on over the last decade or so, we know people categorized as moderate severe psoriasis have higher rates of major cardiovascular events, diabetes, renal disease, and this culminates in about 5 years of life lost. All right, so these are clinical slides of the different variations we have of psoriasis. So the classic is plaque psoriasis, which most of our trials are based on, guttate psoriasis, inverse, pustular, which is a very difficult therapeutic challenge, palmoplantar, in which there's some data emerging how to manage this disease, and then nail psoriasis. I'll just focus a little bit on palmoplantar disease for a moment. So there's two variants. There's classic plaque, where you have these very thick plaques, and then there's the pustular variant shown over here. Often hard to distinguish between one another and hard to differentiate from other disorders of the palms and soles like eczema, pomflex, things of that nature, contact dermatitis. Rarely things like cutaneous T-cell lymphoma, syphilis can present this way, or another disease called necrolytic acyl erythema. Does anyone want to shout out what the viral cause of necrolytic acyl erythema is? Any guesses? Hepatitis C. Yeah, hepatitis C. All right, there we go. You got a C in the front. All right, you've won a free IIS T-shirt, I believe. So purple and green. I hope you like the colors. All right, so that's also meant to tell you there's always differential diagnosis in psoriasis. So, typically you think about other skin diseases that could be involved, unusual skin diseases, connective tissue diseases, infectious etiologies like scabies or tinea. For isolated lesions, we worry about skin cancers like basal cell or squamous cell. And then for widespread disease, we worry about T-cell lymphoma. And so you want to keep this under your mind, because if you're a practitioner caring for these patients, but you're not necessarily a dermatologist, if things aren't going right in the skin, you definitely want to make sure you get the dermatologist involved, because they should be clearing on the regimens you're giving. And if not, perhaps the underlying diagnosis might not be correct. In my practice, I'd say frequently I have patients come in with diagnosed psoriatic arthritis, and they really have eczema. They don't have cutaneous psoriasis, for example. All right, some findings in nail psoriasis. Going to move past that for now. Genital psoriasis I want to focus on. Actually, there's I believe an RCT that's coming out of ixekizumab for patients with localized genital psoriasis, which is fairly successful in that setting. I do have patients in my own practice who only have isolated genital disease and who've cycled through multiple biologics trying to get a hold of this problem. On the right side of your screen is a person who's thought to have genital psoriasis for many years, very itchy. He was using a lot of topical steroids. You see a striae as a sign of that. Does anyone know what his real diagnosis was? Good guess. It was very itchy on the genitals only, a little bit in the glands. It wasn't really that purple or flat-topped. So he had scabies. So we have to keep our brain on. We don't want to be treating infectious diseases with immunosuppressants. All right, scalp psoriasis, again, can be moderate severe. I have a lot of patients in my practice who they only have very bad scalp psoriasis. You can imagine how difficult it is to function normally in this world in terms of social interactions as well as your physical functioning. Patients itch and bleed and have trouble sleeping. Psoriatic arthritis is very common in these patients. The overall prevalence in the population of people with psoriasis is about 10%. It goes up substantially in people who have more severe psoriasis. So we have, if you're a person who's going on medications for moderate severe psoriasis, typically they have prevalence of 20 to 30%. It's often misdiagnosed, especially in the broader community, so it's important for dermatologists to know how to look for this and educate the patients so they know what the signs are to look for and then who to see if they're having a problem. So in my practice, I've had patients who have dactylitis who were told by podiatrists that they really needed to just fracture the toe to treat this problem, not recognizing it was underlying inflammatory arthropathy. Patients who had repeated joint replacements in orthopedic settings, not recognizing that it could be intervened on via anti-inflammatory therapy that could prevent joint destruction. So I won't belabor too much time on the pathophysiology of psoriasis other than to say that this is fundamentally a Th17-driven disease at this point in time. That's how we think about it. It's also characterized by epidermal hyperproliferation, chronic angiogenesis, and a genetic susceptibility architecture. And that's what we think creates this phenotype that we see strikingly both histologically and in our clinical settings. This is a tremendously outdated slide. So this is 2011. We now have double the number of candidate genes. It's not a pretty review article to show you that, so I don't have that. But we have about 70 candidate genes for psoriasis now. Some of these genes already have drugs. So you'll see IL-23, which overlaps both as a Crohn's susceptibility gene and a psoriasis susceptibility gene. We have drugs targeting that, and that will be covered in this talk. This comes back to Len's talk a little bit. I won't do it as eloquently as he did. But what this diagram is trying to show by Andy Blauvelt is this concept of upstream and downstream actions in the immune system. TNF inhibitors, which tend to act a little bit more non-specifically in the psoriasis space. IL-23, which tends to drive production of Th17 cells, which is master cytokine is Th17. And so the concept is that when you're in a TNF world, you're a little more nonspecific and you end up having more susceptibility to a variety of different infectious etiologies, both bacterial, viral, mycobacteria, and fungi. And then when you're in the IL-23, IL-17 pathway, it seems to be a little bit more narrow biologically in terms of what's being targeted. Generally speaking, Candida, which is usually superficial infections, not invasive, or staph, which would be more worrisome in a lot of ways, but actually in clinical practice does not seem to be much of an issue. So this is a paradigm of where the field's gone. So in the 80s, it was barely recognized as being an inflammatory disease. The 90s, people started to recognize that, in fact, this was an immunological disease. We started having the emergence of biologics, some targeting T cells themselves via trafficking. Those were not very successful, either for safety or efficacy reasons. both drugs got removed from the market. And then really in 2005, we started to recognize biologically the importance of the IL-17 pathway in psoriasis. And now in the last couple of years, it's really taken off in terms of therapeutics being available to us. So lots of choices could be overwhelming for a dermatologist or anyone trying to take care of these patients about how to manage this disease. In the biologic space alone, we have 3 TNF inhibitors approved, 1 IL-12/23 inhibitor, 2 IL-23s, and 3 IL-17s, and there's more coming through the pathway. This is a slide I updated like last week. I mean, they're constantly coming to the pipeline. And so I'll try and give you a framework for how to think about this. And I also will say it's absolutely necessary to have choices because people with chronic inflammatory diseases are highly unique. Each one has a slightly different journey through the therapeutic approach of this disease, and we often are stuck with needing more options for people. Now, despite all this progress, the utilization of therapies to control moderate severe psoriasis is quite low in the United States in particular, more broadly in other Western countries. So what this is showing you is a survey of people in the general population, represented the U.S. population. And those who have severe psoriasis, 10% or more of their body involved, roughly only 10% are using systemic or oral therapies, biologic or oral therapies to manage their disease. So 90% of these people are just getting topicals or nothing at all. And so it shows there's a lot of opportunity out there to help people who are currently undertreated. How many of you here have heard the MIPS program? Any MIPS program aficionados? Yeah? And any of you reported MIPS this year? Has anyone reported on psoriasis and MIPS? Any hands for MIPS? All right, awesome. So first of all, I take a little bit of pride in this because some of the data we created was used to design the MIPS for psoriasis. It's really the only outcome-based measure in dermatology, and it was key for our specialty to have at least one outcome-based measure. You know, in rheumatology and GI, they have plenty of outcome-based measures. We really had none. And so the idea is that you want to report on what percent of your patients with psoriasis are achieving these endpoints, global assessment less than 2, so mild disease, BSA less than 3, a PASI less than 3, or DLQI less than 5, which means you have minimal effect on health-related quality of life. You could choose your own adventure, choose the one that you like the most. So in 2015, 1,269 people reported, and about 70% performance rate. So 70% of dermatologists said they were meeting these criteria for their patients. Which is positive in some ways, but shows we have a long way to go. But these are pretty low bars to hit. We actually want to hit much higher bars than this going forward. And let's face it, we all tend to be a little bit more optimistic sometimes when reporting our own data. So it's likely that we have a lot of room to move in improving outcomes in our own practices. Now, the other challenge is that when we use therapies, biologics in this particular case, in clinical practice, they tend to work well early on, and then as this recent paper is showing, they tend to lose response over time. This is drug survival curves showing how long people tend to remain on the drug before they stop it, most commonly for loss of efficacy, in some cases because of side effects. But consistently through these trials, you'll see ustekinumab performs the best. This is the first one to capture secukinumab data, and it did not perform nearly as well as we would have liked to have seen. And there's a variety of epidemiological issues that may be explaining that, and we need more data on that. The other thing I'm showing you is data from our studies, basically showing that when you look in clinical practice how people are doing, their odds of being clear, almost clear, for various treatments for psoriasis compared to what we expect from these bars or from phase 3 clinical trials, we usually don't do as well. And this, again, is because people are losing response over time, or we tend to use the drugs and people are more highly recalcitrant and have truly failed multiple therapies. Next little teaching point I want to give you is that when someone's skin is getting worse, as opposed to better, they are twice worse off from a quality of life standard. So what this is showing you is as when people's when people were going on therapy and their PASI scores were getting better, their DLQI score for PASI of 12 was only about 5. Whereas when they were coming off therapy and their scores getting worse, and they were hitting a PASI of the same number, their scores were around 10. They were twice as affected. And this is something that my patients tell me a lot in clinical practice. They're afraid of losing response. And so you want to keep that in the back of your mind as you're thinking about intermittent treatment versus continuous treatment, trying to maintain response to a drug versus when you're going to switch into something new. So just keep this information in your mind. All right, so principles of biologic therapy. This is probably a strong term. They're immunomodulatory. They're somewhat immunosuppressive. They all carry warnings primarily around infection. Those risks as monotherapy are pretty low in the psoriasis space, maybe more clinically measurable or important when they're combined with other disease-modifying agents of prednisone. So in my practice, what I think about is I want to make sure people are up to date in age-appropriate cancer screenings. This is good routine medical care. I consider vaccinations that they're eligible for based on CDC criteria, including you should start thinking about the new shingles vaccine. The Shingrix vaccine was recently approved. It's part of the U.S. Preventive Health Task Force recommendations for people 50 or older. And so a lot of our patients in our practice qualify. Identifying and treating infections early and aggressively if necessary, educating patients to hold their biologic if they have a significant infection, and there's lots of nuances, and the choice is ultimately often driven by access issues. All right, so these are the TNF inhibitors. I won't belabor it too much other than to say that we have 5. The 2 bottom ones are only approved for psoriatic arthritis, and the top 3 are for psoriasis, and then you have an indication for pediatric psoriasis for etanercept. So you should keep aware of this information because it differentiates how you're going to use some of these drugs, at least if you're dosing on label. I think certolizumab is likely to get a skin indication pretty soon, and I'll show you some data on that. Ustekinumab, this is approved for psoriasis, arthritis, inflammatory bowel disease, pediatric psoriasis, and another drug in that class was withdrawn before it went through phase 3 because of safety signals in cancer, infection, and MACE. All right, we have 3 IL-17 inhibitors that are currently FDA approved, and you can see in parentheses their approval patterns there, so you're aware of what indications they have. Brodalumab is unique between the 3 because it blocks the receptor and therefore may be a little more broadly active in the IL-17 pathway compared to ICSI and secukinumab, which are blocking the cytokine itself. And then we have the IL-23 inhibitors, P19 inhibitors. And so we have 3, of which 2 are currently FDA approved, guselkumab and tildrakizumab, and risankizumab is coming soon. And this is a diagram I think should be helpful for everyone in the room. So these drugs are now being studied in other indications. So for guselkumab, it's approved for psoriasis. It's in phase 3 for arthritis, psoriatic arthritis. It's moving towards phase 3 in Crohn's. So it's positive finding. Tildra is in phase 2 in PSA, phase 2 in Angst-Spond, and then Riza is making progress in PSA, and then is in phase 3 for Crohn's disease. So we'll see if these drugs get the kind of broad applications that we've seen with the TNF inhibitors, for example. I want to make sure we all understand PASI endpoints. So in the good old days, which was not that long ago, a few years ago, we were very happy with this response, a PASI 75, a 75% reduction in how widespread, red, scaly, and thick your plaques were. Now we're trying to get to this phase, PASI 90 response. And that's because we know from a variety of data, hitting PASI 90, the patients have better patient-reported outcomes. So when we look at the DLQI, you can look at this for, and your handouts is more for reference, but basically scores of 0 to 1 mean you basically have no effect on your life from the disease. 2 to 5, you have a small effect, and it's usually considered to be not clinically critical for changing treatment. So we looked at this in a real-world population of patients, and what we found was that people who are only almost cleared their skin disease had about a 20% probability of having moderate or more significant impairment in health-related quality of life, such that you would change their treatment based on guidelines. That was almost not measurable in people who were truly clear. So in clinical practice, real-world patients, we know that being almost clear leaves a lot of patients missing the mark or short of where they want to be. This is clinical trial data now, and again, it's showing you like what's the odds of having no impact on your well-being whatsoever from a quality of life standard based on the DLQI score and your PASI score. So, if you are at PASI 75, you have about a 33% chance, but the PASI 90, you're up to 80% chance. And maybe there's a little bit of a ceiling effect here of getting it completely clear. Some of that may be related to how these measures work. But clearly, I think we'd all agree that there's a big jump from PASI 75 to PASI 90. Also got some clinical data now. So this is guselkumab compared to adalimumab for psoriasis. And adalimumab is an excellent drug, has high efficacy, but what you'll appreciate is similar onset of action for both drugs, but higher response rates, which get more differentiated when we have higher bars of efficacy. This is now looking at the DLQI endpoint over about a year at a time. And it's nice to see these head-to-head trials going on for more clinically relevant time periods because the patients have a chronic disease. 12 weeks is not where they stop. They keep on going on. And so you'll see about a 60% rate of people having no impact on their health-related quality of life on guselkumab compared to roughly 40%. Okay? So that's a very good number, 40%, but we could do even better now with our more modern targeted therapies. There's a busy slide. It's in your handout for purposes of reading and studying. Basically, the rates of adverse events and SAEs, serious adverse events, are quite low across these clinical trial programs, and it's reflected in the labeling of the IL-23s, which really only have warnings around infection, no box warnings, no warnings for malignancy. And you'll see here pretty comparable to adalimumab in terms of all these things that you tend to worry about. When you stop a drug, an IL-23, you have what I call a soft landing, which means that, and this is a treatment interruption design where they say, well, if you hit PASI 75 or PASI 90, we're going to stop your drug, see how long it takes for your disease to come back. As you can see for the PASI 75 folks, 20 weeks later, a good percentage, 60%, are still at PASI 75. So in my practice, I write these drugs for patients who may be going off to college. I may lose them for a little bit, and I know they'll have a fairly durable response even when they come off drug. This is a clinically important slide of how we think about choosing drugs. So they were asking a question of, well, what happens if you go on ustekinumab, an IL-12/23 inhibitor, and then you don't do so well? Would you do well with an IL-23 inhibitor, in this case guselkumab? And so this is the clinical trial design here. And what you see is that for those who are randomized to go on guselkumab compared to staying on ustekinumab, you have a separation. You could do better and get better endpoints, whether they be patient-reported or the higher level clear, almost clear, or higher levels of PASI clearance. And so this is very helpful clinically in practice, right? Because I have people I put on ustekinumab or already on ustekinumab who've done okay but not great. And the question is, what do I do now? Do I use another IL-23? Do I move to an IL-17? Should I think about TNF again? And this data gives me some encouragement to try another IL-23, in this case guselkumab. This is some psoriatic arthritis data, and maybe in the discussion period we have the rheumatologist chime in, but as a dermatologist I'm struck by, let's just look at the left side, the placebo period, that basically at week 24 you have ACR20 response rates for 20, 63%, almost 40% for 50, 16% for 70. This is feeling TNF-like. Which is kind of surprising to me. And maybe in the discussion section we have the rheumatologist comment about where they think IL-23s will shake out as drugs for psoriatic arthritis, because we know IL-12/23 ustekinumab is approved for psoriatic arthritis, but a lot of us tend to feel like it's not as good a drug as TNF inhibitors, for example. All right, tildrakizumab versus placebo versus etanercept. So for those of you who are not in the derm field, etanercept has been around, the first TNF inhibitor approved for psoriasis back in 2002 or 3, I think. If you have a low efficacy drug, you like to compare it to etanercept, because etanercept is our least efficacious TNF inhibitor. And so what you'll see here is that clearly tildrakizumab does quite well compared to etanercept, which is in blue, but not that much better. And I'll show you more comparative data in a minute. And this is, again, safety data. It's a quiet slide. We don't have time to delve on it, but you have it in your handouts for study and on your app on your phone. So this is data that was just presented at Late Breaker at AAD. This is now a study of risankizumab, another IL-23 inhibitor, versus ustekinumab. And looking at 2 different phase 3 trials. All right, so at week 16, 37% of people were completely clear on risankizumab compared to 14% ustekinumab, and the other trial slightly different numbers. At the end of the study, week 52, you have, 60% of patients achieving clear skin, okay, compared to 30% on ustekinumab. That's remarkable. I mean, this is a complex chronic inflammatory disease. 60% of people with no signs of disease in their skin at all. I mean, how often does that happen in RA or inflammatory bowel disease where you hit that type of level of people responding to a single therapy? Striking. And safety, again, was fairly clean. But again, to say that the results are fairly similar. This slide is actually one of a study in Crohn's disease, a phase 2 trial. It came out in Lancet in 2017. And this also looks pretty promising as a therapy for inflammatory bowel disease. You have about 37% of patients achieving remission compared to what looks like 15% on placebo. So similar to ustekinumab, which took a long time to come to market for IBD, now we're seeing very quick studies of these other molecules, and this will help us out for patients who have multimorbidity. This is their safety data here, and I think what's striking about their safety data is that one is the drug looks relatively safe. The rates of severe or reactions relating to discontinuation are most common in those getting placebo, probably reflecting underlying flaring of their disease, and that's another sign of efficacy. And then the serious adverse events, again, tend to be related to GI-related issues that weren't being treated adequately. All right, so this is a summary slide that should be helpful for clinicians. One of the things you want to think about is how often do I want to dose this patient? Or you want to ask the patient, how often do you want to jam a needle in your skin? And so we had the gamut from weekly to every 2 weeks to every 4 weeks to the 8 weeks to every 12 weeks. So the two every 12-week drugs are ustekinumab and tildrakizumab, tildra being the IL-23. Guselkumab is at every 8 weeks. Infliximab gives us some flexibility. It's typically every 8 weeks, but we often will go up to every 4 weeks and adjust the dose. The IL-17s, once you get past their induction, secukinumab, ixekizumab, usually every 4 weeks. What's nice about brodalumab is it's an every 2-week drug. And so each patient's disease is very different. There's some patients who likely need dosing every 6 weeks, and there's some who need it every 3 weeks. And so for my patients who are on IL-17s and have done well during the induction period and started losing response, and they say to me, well, 2 weeks later, 3 weeks later, my joints are a little creaky, I'm getting itchy, I'm starting to get some signs of psoriasis, that's a nice opportunity for brodalumab in that setting because you now can dose them every 2 weeks. This is some information around safety of the drugs, and this really comes straight from the prescribing information, stuff in theory we're supposed to be telling our patients about, or at least the patients are going to be reading about. So we'll start with the TNF story. And these drugs have been out for a very long time, going on 2 decades. They've often been tried in multiple different disease states, so we really understand how they work across many diseases, like there's RCT data in people with CHF. There's RCT data in people with multiple sclerosis. Oftentimes, the drugs combined with serious immunological therapies like Imuran, azathioprine, or prednisone that may result in some of the more stronger warnings. But when it comes down to it, the rate of serious problems in these drugs is relatively low, in the rate of 1% or fewer patients per year. In my own practice, as I tell patients, is that doing this for about 20 years, I can really only think of a handful of patients I've stopped their biologic for having a biologic-related outcome. So the absolute risk seems to be pretty low. But you need to understand the nuances of what could go on. So with the TNF inhibitors, you want to be aware of serious infection, malignancy, exacerbation of congestive heart failure, and demyelinization. Okay? And this will come up when we think about how we pick a drug. This is now a summary of the IL-12/23, IL-23s, and the IL-17s. And so with ustekinumab, the FDA was very worried about malignancy at the time because of what was seen in basic science models, understanding it blocks both IL-12 and 23, and also some of the brodalumab data. So it has a warning for cancer, a warning for serious infections. But you could see in a placebo-controlled period, the rates are negligible. Like 0.3% of patients had a serious infection on ustekinumab during placebo control. So you could tell patients, you could try this drug and see how you do, because the odds of you having a serious problem is really low, at least over the first 3 or 4 months, and that's often reassuring to people. And then also there's one quirky thing called reversible posterior leukoencephalopathy. One case of this was observed in clinical trials. Not clear this has ever been observed again in clinical practice, but you have to be aware of it. It presents with a confusion. All right, so then the IL-17s, they have very benign labeling. The most common things are basically upper respiratory tract infections, and then serious infection is at less than 2%, basically the background rate, which is quite striking. The IL-17s are a little bit different in terms of their counterintuitive effects in the bowel. There was a feeling that they would help inflammatory bowel disease. They actually seem to make it worse, or certainly not help it. In some cases, they may trigger it. And so these three drugs have warnings around inflammatory bowel disease. So your patients who have a history of inflammatory bowel disease, or maybe have a very strong family history of inflammatory bowel disease, well, maybe you want to think about other classes of drugs, TNF inhibitors or IL-23s. And then brodalumab has this quirky thing about suicidal ideation. This is a very confusing finding from the clinical trial development program, but essentially there was a handful of completed suicides and people on the drug at various lengths of time on the drug. And so if you want to use the drug, you need to sign up for a REMS program, which is fairly easy to use, but it's still a little intimidating because there's a black box warning on it, and that's limited its use. So this is a nice summary slide to try and put all these ideas together for you, because it's a huge amount of data to try and wrap your head around. So what I'm trying to show you is histograms. With the top of that bar, the histogram, the odds of achieving a PASI 90, which correlates pretty well with having minimal effects on health-related quality of life, the current standard we're trying to reach in the setting of dermatology. And above that so below that is a slightly different colored bar, which is the background placebo rate, which allows you to calculate a number needed to treat. So you would interpret this by saying, well, for me to get PASI 90, I would need to treat 12 patients with methotrexate to get one person to hit PASI 90 over the background rate of placebo. Okay, that's a lot of people to get there. With a Premolast, it's about 14. So it's pretty uncommon in clinical practice to put someone on Premolast and then see them have clear skin. And you can see with the TNFs, there's some efficacy differences. So I mentioned earlier that etanercept has a lower effectiveness rate, and this is at its double dose, actually, compared to our other TNF inhibitors. Sotorasib literally just read out phase 3 data published in the JAD this week. Literally just came out, and it's pretty striking. You'll see PASI 90 rates around 50%, which is pretty close to infliximab, seems better than ustekinumab, again, not a head-to-head trial. You then get into the IL-17s, which have very high efficacy, the IL-23s, which have very high efficacy, with the only exception being tildrakizumab. Something's going on here. This is not the most effective IL-23 relative to other options out there. So you should be aware of these type of differences between the drugs when you're thinking about which ones you're going to choose. And this is sort of another summary slide. The game Plinko, you may have seen on The Price is Right. I was kind of a sickly child as a kid who stayed home from school a lot. This is on TV a lot. And I would watch it on YouTube because I'm really young. I'm a millennial. And but what happens, you put a chip up here, it'll bounce around randomly, and then you'd hope you'd hit the jackpot. Usually you got nothing. And so that's the difference between a patient seeing a really well-informed physician, practitioner, prescriber, and a patient who's seeing a prescriber who's not as comfortable with these ideas and concepts. So, depending on what your preferences are, if you're looking for long-term data, the TNF still are the champions there. It's certainly emerging with ustekinumab, where the drug's been out since 2009. We have pretty good long-term findings. If you're looking at people with comorbid psoriatic arthritis, the TNF inhibitors are still felt to be the gold standard, although I suspect the IL-17s may rival it, and we'll see what the IL-23s tell us. If they have Crohn's disease or family histories of Crohn's disease, that differentiates it for you. When talked a little bit about cardiovascular disease, I'll talk more about it tomorrow, but the strongest data for cardiovascular prevention so far is in TNF inhibitors. We don't have it in the other mechanisms yet. Patients who have a history of optic neuritis or had Guillain-Barré in the past, these specific things you got to ask about. You're going to move them away from that. You'll probably use an IL-17 where there's some evidence of potential efficacy. The other drugs have been a no in that setting. And then there's other ways of distinguishing that you could study along at home after the talk.